It's my pleasure to welcome you to Grand Rounds and to welcome our speaker, John Ayanian, who's joining us from Michigan. We wish he were here in person, but this is second best. And looking at his CV, he's done a lot of these recently. Dr. Ayanian is the inaugural director for the Institute for Healthcare Policy and Innovation at the University of Michigan, where is the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy, Professor of Health Management and Policy, Professor of Public Policy, and a practicing general internist. His research interests, which relate directly to what he'll be speaking about today, relate to the effects of race, ethnicity, socioeconomic factors, and insurance coverage on access to care and outcomes, as well as the impact of physician specialty and organizational characteristics on quality of care, which are obviously really, really important and relevant to the talk today. He leads a team of 15 faculty members conducting federally authorized evaluation of the Health Michigan Plan, which has expanded Medicaid coverage to more than 700,000 adults in Michigan. He's also served as an associate editor of the New England Journal of Medicine and currently serves as founding editor-in-chief of JAMA Health Forum. In addition to all of this, he has numerous honors, including being elected as a member of the National Academy of Medicine, the ASCI, AAP, being AOA, and a Master of the American College of Physicians. He's received the John Eisenberg National Award for Career Achievement in Research from the Society of General Internal Medicine and the Distinguished Investigator Award from Academy of Health. He earned his bachelor's degree in history and political science from Duke University, medical degree from Harvard Medical School, and a master's degree in public policy from the Harvard Kennedy School. He completed residency and fellowship training in primary care internal medicine at Brigham and Women's Hospital and a postdoctoral fellowship in health services research at the Harvard School of Public Health, and has clearly had a tremendous impact on the landscape of healthcare in Michigan. And I am glad to welcome him today to hear his thoughts about what the Affordable Care Act has accomplished and what lies ahead. Dr. Ayanian.
Thank you, Dr. Barak, and it's a pleasure to be with you all virtually this morning. And I do wish I was there in person, but as Dr. Barak said, this is the next best thing. And I look forward after my presentation to your questions and comments on this very important topic for our country at a pivotal time in terms of the past, present, and future of the Affordable Care Act. And so I'd like to start with a case, and I'm trained as a primary care internist, continuing to practice. In fact, I was working with our residents in the University of Michigan Residence Clinic this morning before changing hats to join you for this Grand Rounds presentation. But I was also a practicing internist in Boston at Brigham and Women's Hospital back in the mid-2000s when Massachusetts was debating state health care reform, what became known as Romney Care, the expansion of Medicaid and subsidized private insurance to low and middle income adults across the state of Massachusetts. And this case, which was a patient interviewed by the Commonwealth Fund around that time of Jim Waterhouse, was fairly typical of many of the patients that colleagues and I were seeing, and maybe many that you have been seeing in San Diego prior to the enactment of the Affordable Care Act. And he was a man who had been working as an engineer in his late 50s and early 60s. He'd been diagnosed with diabetes, hypertension, heart disease, and sleep apnea. And in his early 60s, he lost his job, and because much of our insurance system in this country is tied to employer-sponsored insurance, he lost his insurance at the same time and did not have access to any other affordable option, in part because he had all these chronic conditions that made him very costly to insure in his early 60s, and he was not yet eligible for Medicare, which most Americans become eligible for at age 65. So he became uninsured in his early 60s, cut back on seeing his primary care physician and cardiologist, was not monitoring his blood sugar closely, noted worsening shortness of breath, but didn't come in to have that evaluated. stopped using his CPAP treatment for sleep apnea, and he put off a colonoscopy that had been recommended for a new anemia. And eventually he became so sick that he had to be urgently hospitalized after a delayed visit to his primary physician. And that led to a nearly $50,000 hospitalization to address all of the worsening chronic and acute health problems that he'd had as he pulled back after becoming uninsured. And when he was interviewed after the fact, after he'd recovered, he said, "I tried to put off medical care until I became eligible for Medicare, which complicated my condition." And that was a fairly typical story prior to the Affordable Care Act. And it really led to what I often refer to as the diagnosis of exclusion when we're discussing differential diagnosis in working with medical students or residents. The diagnosis of exclusion, it's what's left after we've excluded everything else. And too often prior to the Affordable Care Act, being uninsured was a diagnosis of social exclusion and economic exclusion from our healthcare system. And particularly for middle-aged adults, it could be quite damaging. And some evidence to support that was a study that colleagues and I did using the Health and Retirement Study, which is a nationally representative cohort study based here at the University of Michigan, funded by the National Institute on Aging. And they track people beginning at age 50 through the remainder of their life with surveys every 2 years, sometimes with physical exam and lab data, and then collecting their health insurance claims as well when they become eligible for Medicare. And what we found following adults, middle-aged adults between age 50 and 65 during the first 8 years of the Health and Retirement Study was, and this was prior to the Affordable Care Act, so in the late 1990s and early 2000s, that adults with diabetes, high blood pressure, heart disease, not surprisingly, had higher mortality than other adults without these conditions. But that increased mortality was particularly severe for those who were uninsured in their 50s and early 60s. And we found that was also compounded among adults in the lowest quartile of income, the bottom 25% of the income distribution. And this combination of chronic conditions that we often take care of as internists and internal medicine subspecialists, combined with low income and being uninsured, was really a triple jeopardy in terms of mortality, as shown here, where those adults had mortality approaching 20% in their 50s and early 60s. So that led to some of the evidence that prompted the enactment of the Affordable Care Act. And I'd like to walk through what some of the key features and effects of that important law were. So if we go back a little over 11 years now, this was the day in March 2010 when President Obama signed the ACA. It was at a time when the Democrats controlled both the House and the Senate. In fact, in the Senate, had 60 votes, so could overcome any filibusters in opposition to the law. And although there was about a 6-month period where there was a hope that healthcare reform could be a bipartisan piece of legislation, the way it was in Massachusetts, when a Democratic legislature worked with the Republican governor Mitt Romney to enact state health reform in 2006. That became a forerunner to the Affordable Care Act, but when it was signed into law by President Obama, it was only with support from Democrats in Congress, some of whom you'll recognize here. At the time, Vice President Biden and Speaker Pelosi were instrumental in the efforts to enact the ACA. But because that was enacted with just Democratic support, it really created a decade of controversy, which we'll all recall as the repeal and replace movement. For Democrats, the Affordable Care Act was the culmination of decades of efforts to build on the creation of Medicare and Medicaid back in 1965, and to extend insurance to a wider proportion of the U.S. population. But for Republicans, they just felt that this was an expensive overreach by government, and really set up the controversies and the battles that we had since 2010. So what were some of the main features of the ACA? So first, it expanded Medicaid for low-income adults, those with incomes up to 138% of the poverty level, about $16,000 or $17,000 a year for a single adult. It created subsidized insurance for middle-income adults through healthcare.gov and state health insurance marketplaces. So California is one of the states that about 15 or 16 states that set up their own health insurance marketplaces under the Affordable Care Act, and the remaining states worked with the federal exchange, healthcare.gov, to provide that subsidized insurance. It also created an individual mandate, which became one of the more controversial parts of the Affordable Care Act, with requiring people to either have insurance or pay an income tax penalty each year at the time when they filed their income taxes. And then finally, to make this all work, they also created health insurance market reforms, such as removing the ability of insurers to exclude people from health insurance because of their pre-existing conditions, and also setting up an essential benefits program whereby certain things like mental health services and women's health services were required to be included in the insurance in order for it to be compliant with the Affordable Care Act. And as I'll discuss later in my talk, the individual mandate and the penalty for it was eliminated back in 2017 when the Republicans under President Trump enacted a tax reform bill that essentially zeroed out the individual mandate. So that's an important feature and one element that Republicans were able to push back on and repeal over the past decade. So I like to say the Affordable Care Act has gone through several near-death experiences, and the first was back in June of 2012. The very first major challenge to the Affordable Care Act was a case that worked its way through the federal courts up to the Supreme Court, where the actual constitutionality of the ACA was challenged. And in a 5-4 ruling, with Justice Roberts siding with 4 of the more liberal justices on the court, they ruled that the ACA was constitutional. But one important feature that had been essentially required under the Affordable Care Act, which was Medicaid expansion, there was a penalty in place for states that chose not to expand Medicaid. They could lose their existing Medicaid federal funding. And the Supreme Court said that was coercive. And so they ruled that states had to be given a choice and they couldn't be penalized financially if they chose not to expand Medicaid. So in 2014, that's when the major coverage provisions of the Affordable Care Act took effect. This shows essentially how our health insurance distribution changed in the United States between 2010, at the time the ACA was signed, and 2020, when some of the most recent data are now available. And what this shows is, as the US population was increasing in size by about 25 million overall, the number of uninsured adults in the United States dropped substantially from 50 million on the right-hand side of this slide to 30 million. So a decline of about 20 million, which was the largest decline in the number of uninsured in the United States since the creation of Medicare and Medicaid back in 1965. Some of that reduction was through expansions in private insurance, although most of that private insurance expansion was just related to growth of the US population, and only a portion of it related to the new ACA marketplace plans. And then the biggest jump was actually in the Medicaid program, as many states, including California, Michigan, and others, chose to expand Medicaid. And that has led over the past decade to an increase of about 26 million in the number of Medicaid uninsured, Medicaid covered individuals, and mostly an increase among adults, because there have been previous expansions for children through Medicaid and the Children's Health Insurance Program. And then finally, the Medicare program, which covers people over age 65, as well as those with chronic disabilities or end-stage kidney disease, That also grew by about 19 million over the past decade, but most of that growth was from aging of the baby boom generation, those born between 1945 and 1965, starting to age into the Medicare program and by turning 65 over the past decade. And so an example of what we saw here in Michigan, for example, in the city of Detroit, the uninsured rate fell by about 2/3 from 22% to just over 7.5% in the first 3 years of the ACA coverage expansions starting in 2014. And in many ways, this was important to a city like Detroit, which had been in bankruptcy early in the past decade and was coming out of bankruptcy and kind of regaining financial solvency and sort of economic vitality. And this reduction in the uninsured rate was felt to be an important contributor to resuming the health and the health of the workforce within the city of Detroit. And as might be expected, this shows what happened by income category to rates of uninsurance. So prior to the ACA coverage expansion, so in that period from 2010 to 2013, for those who were poor, living below the poverty level, about $12,500 a year, or near poor, between 100 and 200% of the poverty level, up to about $25,000 a year, their rates of uninsurance were at or above 40% during those several years before ACA expansions took effect. Whereas the rates of uninsurance for adults with incomes above 25,000 were much lower in the 10 to 12% range. And what we saw between 2013 and 2015 was a really dramatic drop by almost half in the proportion of poor and non-poor, poor and near poor adults who were uninsured. And even through 2018, still a much lower rate of uninsurance in that group, down around 25% compared to just over 8% among those with higher incomes. And it's also played an important role in reducing racial and ethnic disparities in uninsurance. So prior to the ACA, the rates of uninsurance were highest in the among Hispanic adults in the United States, followed by non-Hispanic Black adults and non-Hispanic Asian adults. And all three of those groups have seen significant declines, but especially among Black and Hispanic Americans, the most substantial declines in uninsurance rates. And so the magnitude of disparities in uninsurance are substantially smaller, again, reduced by about half compared to where they were a decade ago. And so we've also started to see now some improvements in access following those improvements in coverage. And that has applied particularly to Black and Hispanic adults, who have seen larger reductions in reporting avoiding care due to the cost relative to white adults. So again, helping to narrow some of the disparities in access that we see in the US. But the picture still remains very uneven geographically across the country. So this is a pattern several years ago, but it's still largely in place, whereby states in the Northeast, Mid-Atlantic, and Upper Midwest, as well as the Pacific Coast, have generally had rates of uninsurance after the ACA took effect of less than 10% or maybe up to 12%, whereas states in the Deep South and Southwest have had persistent rates of uninsurance approaching 15 to 20% overall in their population, with a couple exceptions. So, for example, in the South, I would point out that Arkansas, Kentucky, and West Virginia, which were the only three Southern states to initially expand Medicaid, had lower rates of uninsurance than the neighboring states that chose not to expand, as shown on this map. And that corresponds closely to what states have decided in response to that 2012 Supreme Court decision, whereby initially about 26 states chose to expand Medicaid. And since 2014, another dozen or so states, so now a total of 38 states in the District of Columbia, have chosen to expand Medicaid. And some of the recent Medicaid expansion states are fairly conservative red states where actually voters have voted to expand Medicaid. So states such as Missouri, Oklahoma, and Idaho have either expanded or, in the case of Missouri and Oklahoma, are in the process of implementing expansion, whereas the states shown in orange here, primarily in the Deep South, as well as some in the upper Midwest, have chosen not to expand Medicaid. And that really, in large part, helps to explain why they have the persistently high rates of uninsurance shown on the prior slide. So I wanted to share some of the evidence that we've been collecting from Michigan over the past 7 years. And I moved to the University of Michigan from Boston back in 2013. And very shortly after I arrived, actually, Michigan followed a pattern that was more similar to what I had seen in Massachusetts, where there was actually bipartisan support for expanding insurance coverage. And this was the governor's signing ceremony after all of the Democrats in the legislature and about half of the Republicans came to agreement on a Medicaid expansion plan. And we were one of the first Republican controlled states. So at that time, we had a Republican governor, Rick Snyder, as well as Republicans controlling both houses of our state legislature. But together, they were able to see the benefits, the potential benefits for expanding coverage. And so this was the signing ceremony that included in this photo Representative John Dingell from southeastern Massachusetts, who was also sitting next to President Obama in that signing ceremony for the Affordable Care Act, as he had been a longtime advocate of expanding insurance coverage in the United States. And so I wrote about Michigan's approach because it required that bipartisan agreement. The Democrats in the legislature were strongly in support of expanding coverage. And with introducing some market-oriented reforms to the Medicaid program, which actually required a federal waiver, because Medicaid is a federal state partnership program, where in most states, the federal government provides somewhere between half and 2/3 of the funding for the Medicaid program, and states provide the rest of the funding. So in Michigan, they sought what's called a Section 1115 waiver to expand Medicaid, and with an added emphasis on primary care. So everybody who enrolled was required to sign up for a primary care provider. And we have a substantial proportion of our Medicaid enrollees are covered in managed care plans, about 85%. And the managed care plans actually had incentives for ensuring that their new enrollees were getting connected with primary care. And then a key piece of our Medicaid expansion was the introduction of more cost sharing for Medicaid enrollees, fairly modest, on the order of $2 to $4 for office visits and up to $10 for prescriptions, and somewhat higher cost sharing, for example, $25 for emergency room visits and $200 for non-urgent hospitalizations. There was also financial incentives for healthy behaviors, whereby new enrollees could reduce their cost-sharing obligations if they worked with their primary care physician to quit smoking or get more physical activity or follow through on preventive services that were recommended. And then finally, something fairly new to the Medicaid program was that our legislature created My Health accounts, which are like health savings accounts and historically have not been used within the Medicaid program. But these were quarterly statements that Medicaid enrollees received, showing both what their healthcare costs were, what the program was spending, as well as what their cost sharing obligations were. Although it's important to note that there was no financial penalty in terms of, or risk of being excluded from the Medicaid program for people who did not pay their cost sharing. And I think the legislature and the governor really came to agreement because they saw an opportunity for better access for about 7% or more of our 10 million residents of Michigan who would qualify for expanded Medicaid. And then our healthcare community was also instrumental. The Hospital Association, State Medical Society, Nursing Association, all came together to advocate very strongly because of the federal funding. Because in the first 3 years of Medicaid expansion, the federal government paid the 100% of the cost. And that dropped down to 90%, which is still substantially higher than the 50 to 70% that the federal government pays for traditional Medicaid spending in states. And then finally, our business community actually came together. And I think this has played a strong role, particularly in encouraging our Republican legislators to support this. So our Chamber of Commerce and Small Business Association actually came out in favor of Medicaid expansion because they were concerned about cost shifting in our healthcare system, whereby the costs of uninsured patients may be shifted to those with private insurance through higher negotiated rates. So it was really, I think, a true political compromise of a number of different stakeholders coming together to support this expansion. And so over the past 7 years, as part of that federal waiver for the Michigan Medicaid expansion, we've put together a team, as Dr. Bark referenced in her introduction, of 15 faculty from 5 different schools on campus here at the University of Michigan. So physicians working with social work faculty and health economists and statisticians to evaluate the health and economic effects of Medicaid expansion. And in fact, much of our work was featured in the Washington Post in a front page story about the Affordable Care Act right around the time when the 2020 presidential campaign was starting to ramp up, and the future of the ACA was being actively debated as part of that presidential campaign. So I just want to share some examples of some of our findings from looking at Medicaid expansion here in Michigan. This was a study led by Renu Tipernini, one of our general medicine faculty, summarizing a statewide survey of Medicaid enrollees during their first 2 years of coverage. And what they told us was that about 40% said their mental health or dental health had improved during the first year of coverage. Nearly 50% said their physical health had improved. Those who were not working, over half, 55%, said they were better able to look for a job. And for those who had jobs, 69% told us that they were more effective in their work, or they were able to apply for a higher paying job because they didn't have to worry about their healthcare expenses and were getting their chronic conditions treated. And I'll particularly underscore the benefits of dental coverage in this population. Many of these new enrollees told us they hadn't received any dental care for 10 to 15 years before joining the Healthy Michigan Plan and the Medicaid expansion. And because our legislature opted to include basic dental benefits, which is an optional benefit under Medicaid, many of our new enrollees, I think, took advantage of that and told us that was actually very important to their well-being, and even helping them to work, for example, if they were in customer service positions or aspired to move up into those positions, having better care of their teeth was an important part of their overall health. We also looked at the economic effects of Medicaid expansion on our state economy, working with the group at our Department of Economics here at the University of Michigan that does the economic forecasts for the state and the state budget. What we found was that this infusion of federal funding and expanded coverage was associated with an increase of employment of about 39,000 jobs in the state in 2016, 2 years after Medicaid was expanded. And that was projected to remain above 30,000 jobs, new jobs created through 2021. And those new jobs and the $3.5 to $4 billion of new federal spending were associated with nearly $2.5 billion of increased personal income in the state. And that increased personal income through income and sales tax generated about $150 million of new state tax revenue. So we really saw a ripple effect throughout the state economy. So not just in healthcare employment, but what our health economist colleagues refer to as the multiplier effect. So as new spending in healthcare leads to new employment in the healthcare system, those healthcare workers are spending money in other ways, in retail, in real estate. It also took some of the burden of uncompensated care off the state and local budgets. And allowed our state revenues to be invested in education or transportation, roads, and other infrastructure. So essentially a net benefit. And this has actually been a powerful argument in some of those red states like Oklahoma, Missouri, Idaho, Nebraska, Virginia, those states that have chosen to expand Medicaid since 2016, recognizing these economic benefits that the non-expansion states are missing out on, even though those residents of non-expansion states are contributing tax dollars. So when we look at what Medicaid expansion has meant for the state of Michigan, now we can say that the coverage and access to care has improved for approximately 1 million low-income adults in the state. And are, in fact, during the pandemic over the past 18 months, as there have been some changes to Medicaid regulations to extend coverage, we've actually seen growth from about 700,000 to 1 million enrollees in our Medicaid expansion. And that's been a very important part of the safety net during the employment shifts and some of the illness, profound illness that we've seen during the COVID-19 pandemic. We can also say that financial outcomes have improved substantially for enrollees and hospitals in the state, with costs offset in the state budget. So we've had essentially no hospital closures, and the hospital margins have improved substantially among the 100 plus Michigan hospitals since Medicaid expansion. And then finally, many enrollees have reported that their physical, mental, and dental health and their ability to work has improved. And that is particularly prevalent among those with chronic conditions such as diabetes or depression or asthma or COPD. Just to share some of the evidence from other studies about Medicaid expansion, this was one published in JAMA Surgery 3 years ago, looking at Medicaid expansion states relative to non-expansion states in terms of timely presentations and optimal care for 5 major surgical conditions where we know early diagnosis and treatment for conditions such as acute appendicitis, cholecystitis, diverticulitis can make a substantial difference in improved outcomes and preventing some of the more severe complications such as peritonitis or sepsis. And so what we see is that in the left-hand slide, the probability of early presentation, which was about the same in the years before the Affordable Care Act among expansion and non-expansion states. There's a widening gap since 2013 in that risk of late presentation. So the non-expansion states shown in orange relative to the expansion states in blue, where early presentation was much more common, including among Medicaid and uninsured adults in those states. And then there's also a widening gap in terms of optimal care for those patients with acute major surgical conditions. So showing that this doesn't just apply to chronic medical conditions, but also acute conditions as well. And another study that came out last year looked at the role of Medicaid expansion in southern states, essentially comparing those 3 southern states, Louisiana, Kentucky, and West Virginia, to those that did not. And among patients with chronic health conditions who were already connected to treatment in community health centers in those southern states, what they found was that fewer people experienced a health status decline. About 1 in every 4 people who gained coverage were less likely to have a decline in their health status relative to very similar adults who were also getting care at community health centers in non-expansion states. So it shows that the safety net is important, but insurance coverage adds to the safety net provided by safety net hospitals and community health centers, and that that safety net coverage cannot be viewed as an adequate substitute for insurance coverage, because even when people can get care in community health centers, it's often focused on primary care and they don't have access, or they have substantial difficulty getting access to effective specialty care. And then my colleague, Sarah Miller, who's a health economist here at our business school at the University of Michigan, published this study initially with the National Bureau of Economic Research, and last year published the peer-reviewed version in the Quarterly Economic Journal, What she found was that comparing adults in middle age, so those who are between 55 and 64 in expansion and non-expansion states, prior to 2013, they had a very similar mortality pattern. But in fact, after 2014, she saw significant and widening differences in mortality where adults after age 55 were less likely to die in Medicaid expansion states relative to non-expansion states. So not only does the ACA improve coverage and access to care for chronic diseases and acute conditions, but we're also starting to see evidence of improved health outcomes. So in the remaining minutes of my presentation, I'd just like to talk about some of the challenges and resilience of the Affordable Care Act and the prospects for it going forward. So the second near-death experience was the vote in the US Senate to repeal and replace the Affordable Care Act in July of 2017. So this was about 6 months after President Trump had been elected. He had campaigned on a plan to repeal and replace the ACA and was elected with Republicans in control of both the Senate and the House in the first 2 years of his presidency. And this vote came very close. This was the dramatic moment in the middle of the night when John McCain indicated he was voting no on the repeal and replace bill, which had already passed the US House, along with Lisa Murkowski from Alaska and Susan Collins from Maine. Those three Republican votes caused the effort to repeal and replace, which had really started shortly after the Affordable Care Act was enacted back in 2010, caused it to fail by just one vote. And some of the key things that this repeal and replace bill would have done would have converted Medicaid to a model of per capita funding rather than an entitlement program that would have limited the growth in spending. It would have phased out the enhanced funding for Medicaid expansion, cut back on marketplace subsidies for premiums and cost sharing, and it would have allowed more age variation in the marketplace premiums. So on healthcare.gov or on Covered California, right now, there's a fairly narrow band of premium differences. About a threefold difference can be charged between younger adults and older adults approaching age 65. And that would have expanded to a fivefold difference, which would have reduced the premiums for young adults in their 20s, but would have substantially increased premiums for older adults in their late 50s and early 60s and made that marketplace coverage much less affordable. And then finally, it would have repealed most of the ACA-related taxes that helped to pay for the expanded coverage. And even though the repeal and replace bill failed in the US Senate, President Trump signed executive orders that I think trimmed some of the scope of the Affordable Care Act, is what we can say, and weakened some of its components. It cut back on cost sharing and risk adjustment payments that were provided to insurers for the marketplace plans, cut back on the advertising funds and outreach funding by about 90% that had helped people to get enrolled in the early years of the program. The Trump administration improved work requirements in a number of states for adults without disabilities to retain their Medicaid expansion coverage. It was only implemented in one state, Arkansas, for several months before being stopped by a federal judge. And in fact, the Biden administration has indicated that it won't allow any Medicaid work requirements to go forward. So that's less of an issue at the present time. And then finally, as I mentioned in my opening remarks, the 2017 tax law enacted in December of 2017 eliminated the tax penalty for the individual mandate. So what's interesting about public opinion on the Affordable Care Act is that if we go back to 2010, and particularly for the first 3 to 4 years after President Obama signed the law, the country was pretty evenly divided, with about 40% of the population supporting the ACA, about 40% opposing it, and the remaining 15 to 20% being undecided about whether the ACA should continue or not. In 2014, when there were all the problems with healthcare.gov and people were having trouble signing up through the healthcare.gov computer system, the ACA opposition actually grew to a little over 50% in 2014 before some of those problems were tackled. And I think we settled back into this evenly divided picture. But it was really in 2017 when the Affordable Care Act was under threat of being repealed and replaced with a less extensive system of coverage that we saw the blue line on this graph start to increase and really have seen a little over half of the voting population supporting the ACA and a decline in the opposition or the unfavorable views of the ACA down below 40%. And that shift in public opinion, in my view, has really been instrumental in maintaining support for the ACA going forward. And when we look at how that breaks out by party affiliation or among independent voters, what we can see here is that some of the core elements of the ACA, when you separate them from the law overall, have always been very important. So the support for the marketplaces and the exchanges, the subsidized private coverage for middle income adults, that has always been up around 80%. It does vary from above 90% among Democrats to just around 60% among Republicans, but still strong majorities in support of those components. And we can say the same about Medicaid expansion. I think that's one of the things we've learned over the past 5 years or so, how much the public values Medicaid. And even though at any given time it may only cover a quarter or so of the U.S. population, many people have been covered or had their family members or friends covered by Medicaid at some point in their lives. And so they've come to appreciate that as an important part of the safety net. And it's really only the individual mandate as a specific component of the ACA that was never very popular, only about 35% of voters supporting it, and primarily among Democrats, with much less support among independents or Republicans for that feature of the law, which now is no longer in effect. And there's also been very substantial public support for some of the other less publicized but important features of the Affordable Care Act. So the expansion of family insurance plans to adult children up to age 26, the elimination of cost sharing for effective preventive services like mammography or colonoscopies to screen for colon cancer, both supported by upwards of 80% of adults. And then the closing of the Medicare Part D donut hole, that gap in coverage after the first several $1,000s of coverage, where people lost coverage, and sometimes among the sickest Medicare enrollees, that donut hole has been closed. And so that is very popular among voters, particularly Medicare beneficiaries. And then the elimination of exclusions for pre-existing conditions, supported by 2/3 of voters overall, and majorities of Republicans supporting each of these dimensions. So the most recent near-death experience for the Affordable Care Act was a Supreme Court decision in June of this year, just 4 months ago, when a lawsuit that was brought several years ago in 2017 by 20 Republican attorneys generals argued that because the tax penalty had been eliminated for the individual mandate, and because that was the grounds on which the Supreme Court in 2012 had ruled the law constitutional, that now the Supreme Court needed to declare the whole law unconstitutional. And initially, the judge who heard this case in New Orleans deemed that the individual mandate was both essential and non-severable, meaning it couldn't be separated from the rest of the ACA. That lawsuit by Republican attorneys general was challenged by 17 Democratic attorneys general, including Xavier Becerra, who at the time was the California Attorney General and now the Secretary of Health and Human Services under President Biden. They defended the ACA, and in June, the Supreme Court ruled with a surprisingly strong 7-2 majority that the states challenging this law don't have standing based on the waived tax penalty because they're not directly affected by the individual mandate. And they left the ACA essentially unchanged, but also signaled that this challenge, even if it was brought by individuals with standing, would not be upheld by the ACA. So that's really the latest survival that we've seen of the ACA. So in closing, I'd just like to underscore how resilient the ACA has remained despite these legal and congressional challenges. As of 2021, we have nearly 15 million, or as of prior to the pandemic, we had nearly 15 million newly enrolled in Medicaid, and that actually rose by another 11 million over the past year during the pandemic. And we have 11 million enrolled in the ACA exchange plans, healthcare.gov, and the state marketplaces, and that rose by about 1 million during the pandemic. As I mentioned, 5 states have expanded Medicaid just in the past 2 years, 4 of them after the voters, majorities of voters in these fairly conservative states, Idaho, Maine, Nebraska, and Utah voted to expand Medicaid. And in Virginia, it was after the Democrats gained control of the governor's office and 1 house of their legislature that they were able to negotiate a compromise with a handful of Republicans to expand Medicaid. And then 2 states voted to expand Medicaid in 2020, Missouri and Oklahoma. So I'd just like to close with highlighting what I see as some of the crucial questions for US health policy in the next decade. This was an editorial that I wrote in JAMA in a special section focusing on health policy under the new Biden administration. And I shared this article with the residents in your department as providing some further context for today's discussion. And I posed 4 different questions that I think are going to be crucial for our federal and state governments and stakeholders across the healthcare system to address. First, who remains uninsured and how can they be covered? Second, who remains underinsured? So with high cost health plans or high deductible plans or expensive marketplace plans, how can their costs be made more manageable? Third, how much healthcare spending can the United States as a society and an economy afford? We've actually seen an important leveling off of what had been a steady growth of healthcare spending over the 30 years from the mid 1980s to the mid 20-teens. Significant increases every year in healthcare spending relative to a proportion of the gross domestic product. But what we've seen in the last several years is that the healthcare spending has remained fairly steady at about 17 to 18% of the gross domestic product, the national economy. And the question is, as we come out of the pandemic and deal with some of the pent-up demand for healthcare, how can we control those costs and what can we afford? And then finally, an important question unmasked by the pandemic over the past 18 months, but one that's been long persisted in the US healthcare system, how can we eliminate racial, ethnic, and socioeconomic disparities in health outcomes in the United States? And I would argue that the Affordable Care Act, particularly the Medicaid expansion, has been an important start in our efforts, but it's necessary and not necessarily sufficient to eliminate disparities, as we've seen during the COVID-19 pandemic, where structural racism and social determinants of health and unequal opportunities, both inside and outside our healthcare system, contribute to profound racial, ethnic, and socioeconomic disparities. So in terms of the future of healthcare reform over the next decade, with the shift to the Democrats controlling the House of Representatives in 2019 and the Senate this year, Republicans are unable to repeal and replace the Affordable Care Act. With Medicaid expansion and coverage of pre-existing conditions remaining very popular, the future of the ACA will be determined by the Biden administration's executive orders and regulations, by congressional action, which we're in the midst of right now, what comes out of the budget reconciliation process, which it could include further expansion of Medicaid or expansion of Medicare or neither, depending on what the Democrats are able to negotiate within their caucus. And then finally, will there be a public option in the ACA insurance exchanges? Another important policy decision going forward. So, a decade ago, it would have been more straightforward to repeal the Affordable Care Act. But as millions of Americans through Medicaid, through coverage of young adults, through the marketplace coverage, have gained benefits from it, I think it's become much harder. And this helps to explain why Republicans, when they had control of Congress and the White House, were unable to repeal this important law as they had originally intended. So I'd like to end my presentation there and open it up for questions or reactions. If you're interested in learning more about some of the work I described at Michigan about the Affordable Care Act and Medicaid expansion, our institute website is shown here. And also our Twitter feed where we release much of the new evidence as it's coming out. So thank you for your attention.
So thank you very, very much for such a stimulating overview and really thought-provoking. We do have a couple of questions for you. So let's start with the first one, which is from Dr. Baxi. Looking at what is happening to Roe versus Wade, even after 50 years, what do you think? Do you think the Republicans will continue to chip away at the ACA in the future? And I guess the question that I'm adding to that is, I was going to ask, which is how to, I don't know that there's an answer, but how to avoid these continuous fluctuations based on the political environment to create some stability. I agree with you that it's very integrated into the landscape right now, and the more time progresses, the harder it will become. But how do we stabilize that?
Well, I think first and foremost, what we've learned is that voting matters. We saw how close the last presidential election was in some of the key swing states. We also saw in congressional voting or Senate voting, for example, in Georgia, where the control of the Senate was decided in a runoff election with a very narrow margin. So I think for our democracy to function effectively, we need voter turnout to be as robust and as possible, so that the actions of our legislators at the state and federal level are reflective of the views of voters. And whether those views trend more conservative or progressive, we're better off with strong and robust voter turnout. So I think maintaining free and fair elections and getting people motivated to vote, I think, is going to be absolutely critical. I think this, as long as we remain such an evenly divided country politically, if the Republicans were to regain control of Congress and the White House, they very well may try again to repeal and replace the Affordable Care Act. I think as long as, at least for the next 3.5 years or so, as long as President Biden is in office in his current term, it really would be very difficult. The only way the Republicans could repeal the ACA would be to elect, 2/3 majorities in both the Senate and the House. That would be, where they could repeal the law and, overcome a presidential veto, because President Biden would certainly veto such an effort. So I think it's for the most part, I think we'll have the status quo for the next 3.5 years, but this will all be in play again in the 2024 election, depending on how that plays out.
Thank you. And then we have another question. Has the profession done enough to remove the impediments for universal health care? Of note, the pandemic has demonstrated that lack of mandates for just COVID-19 vaccine coverage has resulted in bottlenecks in care for all other healthcare needs, regardless of insurance coverage, thus affecting the ability to provide quality care to all. So I guess the bigger question there is, what's the pandemic done to healthcare and the future of healthcare going forward, that you alluded to a little bit?
Well, it's been an incredible shock to the healthcare system, and in every conceivable way, and the burnout and distress we're seeing among our healthcare workforce, in the strains on the supply chain, and early on the potential shortages of ventilators, more recently some of the concerns about access to effective treatments once people have COVID. And so I think it's really causing a top to bottom reevaluation of how our system is structured. And absolutely at the state and local level and the federal level. But I think we all, most healthcare, while it's funded at the state and federal level, it's delivered at the local and regional level. And we've seen such a wide variation in terms of how well different states and regions have handled the pandemic, both the distribution of vaccines, but then also with the stresses on the hospital system and critical care services, the ability of hospitals within regions to collaborate and cooperate, sometimes with state help and support, sometimes just with the healthcare organizations on their own. So we're in a very unsettled time. I think in many ways it remains an exciting time, because we've demonstrated when healthcare, both preventive health and healthcare delivery, works well, how much we can accomplish. But it also demonstrates how even that progress is, and how far we have to go. So encouraging all of us as healthcare professionals to be as involved as possible in the decision making in our own healthcare systems, and advocating for what we view as good policies with our local, state, and federal officials.
Right, because I agree with you. I mean, I think what COVID has highlighted is the local delivery and how variable it is, in a way that I don't know that most of us envisioned. And I think that that's exacerbated a lot of the impact. Just speculating, this question is from me because I don't see other questions. What do you think has led to the stabilization in the overall expenditure on healthcare costs? Because it was projected to just continue increasing, and it's going to be important in terms of projecting for the future. I did read your editorial, and the notion of needing to keep it at under 18%. It's easy to say, but just much harder to do. So what do you think it's going to take?
Well, we've been paying more attention to healthcare costs as a society, and our policymakers have for the past decade or so. There are some features of the Affordable Care Act, such as the emphasis on value-based payment, that even though the direct evidence about those programs is very mixed. They've had sort of, for example, accountable care organizations have had modest effects on controlling costs. I think they've signaled sort of an importance of a new attention among providers to thinking about value-based care as opposed to just volume-based care, that which is what we lived with during the 30 or 40 years when the fee-for-service system was really unfettered, and for the most part, patients and doctors were seeking whatever services they thought might be effective regardless of the cost. And another important feature is the growth of high deductible health plans in the past decade. So many more insured individuals and families have deductibles over 2,000, 3,000, sometimes upwards of 5,000 or 10,000, where they're responsible for the first several $1,000s of expenses. I think that makes people more price sensitive and cost sensitive. And I think some of it's been a reaction that our healthcare organizations now recognize that if we don't control costs, there are going to be more drastic measures that policymakers or insurers may start to impose. So I think to some degree, all of those factors are coming together, to kind of blunt the cost, and to the extent we also need to have a growing economy, because this is the main. When we say healthcare spending is 18% of the healthcare of the overall economy, if the economy is growing and becoming more productive, we can afford more healthcare. Whereas if the economy is stagnating, what we spend on healthcare is likely to grow as a percentage. So, we already spend substantially more. The rest of the high income countries spend more on the order of 8 to 12 or 13% of their economies on healthcare. So we already spend more. We just have to spend more wisely. And I think we have the capacity to do that, but it will require a multifaceted approach.
Yeah, maybe we can have you come back in a couple of years to talk about how we can actually do that and how we can spend our dollars more wisely, because we are not ranked that high given how much we do spend on it. So
no, I would be happy to do so, and hopefully the time when we could all meet in person as well.
that would be great. So thank you so much. Thank you for such a stimulating and illuminating and thought-provoking talk. We appreciate you joining us. So
My pleasure.